Good morning, everyone. You
Good morning.
Morning, Doug.
guys hear me okay?
Yep.
Great.
We're still waiting on a few people here, so we will give it a little bit. Might start a couple minutes
Yep.
after. So.
Sounds good. I just figured that I was going to have, probably 5 minutes of technical difficulties. So, but that it just worked. It worked on the first try. I couldn't believe it.
Excellent. Morning. Well, I think we're ready. So let's go ahead and get started. Welcome to those of you that are here in the room and those online to our Prescription Drug Affordability Board meeting. Just want to welcome you all here today. Let's go ahead and start with this introductions of the board members. Mary Ann Lindblad, Chair.
Hong Chong Board Member.
And online, Doug and see.
I'm Greg Gibson.
Greg, Doug,
Doug Barthel, board member.
and we'll perhaps have Eileen Cody joining us at some point in time. She's enjoying her time in Mexico right now. So we'll wish her well. And then just go ahead and go around the room who's here and then staff that are online. So Brian, do you want to start?
Sure, I'm Brent Bisbessy, the Assistant Chief Privacy Officer here at HCA.
Mike Noenschwander, the manager for the Prescription Drug Affordability Board.
Assistant Attorney General Michael Tunick. I am legal counsel to the board.
Hey, Simon Borman, policy analyst for the board.
And then staff online. Sorry, just initials.
I'm Kelly and I'm the PDAP data analyst.
And this is Marina Suzuki. I'm the Health Economics Research Manager.
Anyone else?
I'm Jing Ping. I'm the Cost and Quality Analytics Manager in HCA.
Great. So thanks to all and to all those attending. And we'll go ahead with the PDAP Director's Report. We've got a full agenda today, so we'll want to get moving.
Yep.
Thanks, Mike.
Okay. Thanks for everyone for coming out today. Always appreciate having the time to chat and work with you all. So our big thing that we've been working on here for the last little bit is trying to gather data and prep for our drug reviews that we're putting together. So really the big things that we've been doing are working on collecting data from a variety of sources, including manufacturers, putting out surveys for people to review, getting reports from the advisory group members, and then also pulling internal data to try and fill in pieces that we have available through that type of data. And so we will be chatting more about our drug reviews here today. We'll have a closed session for a little while to go over some of our, where we're at in our first draft and what we have, what we're still working on. So we'll take a little time, I'm guessing probably an hour to meet with the board on that, show them what we got and see what questions that they have. So for that piece, the board members will go to a separate online meeting, and then we'll just ask people to clear out the room temporarily while we're doing that. After that, we have a few other presentations around our new drug list that we're developing, as well as for the next year of eligible drugs, as well as beginning discussions on upper payment limits. That'll be, I think, very interesting. In terms of kind of some other interesting things that are going on in other states, Maryland is also working on UPLs and how to implement those. And they're beginning some new reviews on some other drugs. And they've gotten a little bit of legislation to expand the board's authority to cover all payers statewide. So that will be interesting to see how that works. Colorado, as we know, last fall set their first UPL on Enbrel, which was effective January 2027. The original Amgen lawsuit was dropped that they had, but they started a new one, basically with a lot of the same constitutional arguments, but appealing on the UPLs causing harm to them. So other drugs that Colorado's done some reviews on 4 other drugs, and if you guys want a little bit more information on the lawsuit, the Colorado Sun has a good article going and explaining that. Oregon has completed reviews on some of their drugs and determined Cosentyx, Trulicity, Vraylar to have affordability challenges. And then they did get a little bit of change in their legislation. They were required to review insulin products, at least one insulin product. They got the legislation changed to say that they may review insulin products, so that way that gives them a little more flexibility in terms of how they're able to work with their drugs. And a broader report is going to be forthcoming with the drugs reviewed that were reviewed in 2025 with the board recommendations on those. Minnesota has a relatively new PDAB director for their state, Vernon Rowan. So he's beginning to stand up their PDAB. New Hampshire's PDAB, due to budget difficulties, was actually eliminated. So that's something happening over there. And so really timeline that we're trying to work on here, generally speaking. So again, reviewing our initial draft drug review today, hoping to have things kind of finalized and filled out more for our May meeting. Then in June, per the legislation, we are required to give a new list of eligible drugs for us to begin thinking about that can be reviewed. So working to get ready for that. And then also, again, UPLs for us will come into effect in 2027. But in order to get ready for that, we need to start crafting and working on the WAC language now, so that way it can be ready for the 2027 calendar year. And then, of course, those new rules won't come into effect until after the 2027 legislative session, according to the policy that we have. So a lot of things starting to happen here, and then just dates for upcoming board meetings: May 20th, July 15th, September 16th, and November 18th. And we'll adjust as needed if we need to, but that's what we tentatively got on the schedule right now. So questions, thoughts, or comments on that?
Ms. Mike, are you seeing any other states considering setting up PDABs?
So I know there's been a few other states that have had some legislation in the work. Ryan, do you remember off the top of your head who, if there's any new ones besides the ones we've been working with recently?
Yes, I believe that there are some, and I believe that they may be looking at a different kind of model legislation that may tie more into the Medicare price, negotiated price, using that as kind of some of the language embedded in the statute. But I don't know which states may
That's
have.
okay, just curious.
I thought Virginia might be one, but I can do a quick check.
And I think Maine, I remember someone saying something about Maine potentially doing that as well.
Yep.
So yeah, the ones that we kind of coordinate with and meet with very regularly are Maryland, Colorado, Oregon, Minnesota. And so those are the ones. There's some differences again with all the states and how their PDABs work and what rules and restrictions they have in terms of reviewing drugs. For example, Oregon doesn't have UPL authority, but yeah, those are the ones that we probably collaborate with.
And looks like Eileen has joined us. Welcome.
Good morning.
Good morning. Glad you can make it.
We're just all jealous.
It's pretty nice out here.
It's pretty rainy here.
And it snowed right after we left, so I'm glad I got out of there.
Okay, any other questions?
Right. We're ready to go on. Were you going to change up the agenda?
Yeah, so I think we were going to switch up our schedule just a smidge. So we will go with Kelly's presentation first. Just again, a reminder of, how our eligible drug list is created. Going over how we were weighting and ranking those to create, a list of drugs that we could choose from. And so just kind of a refresher on that, so everyone is up to date and prepared for as we're starting to come into June, which isn't too far away, and we're going to have a new eligible list of drugs that we can choose from, and then some new drugs that we can select for drug reviews for the next year. So, Kelly, I will let you take it away.
It's thinking. Okay, can you see my slides?
Yep.
Do you see my notes?
Not your notes.
Okay. Okay, great. So it's been a while since we pulled our initial list of eligible drugs for affordability reviews. So we thought it would be helpful to briefly go through the methodologies we used. Because I'm not going to lie, I had to review my own notes when I created this presentation because it has been so long. So some of these slides might look familiar because I just collated the slides from previous presentations. So I'm not going to get into great detail about the methodologies we use since this is going to be a refresher and there's a lot to cover in this presentation. So if you do need a more in-depth refresher, you can go back to the presentations from our previous board meetings. Okay, so I'm going to go over the methodology for including
Are you there?
I can't hear anything.
Yeah, I can't hear it. Kelly? Kelly, we can't hear you.
I don't know if she can hear us. Kelly.
Let me reach out and see if we can find where she went. I'm just gonna call in.
So sorry about that. My audio loves to drop out at important moments. So I'll just, so like when did I drop out like when I was talking about this slide or when I went to this slide?
I think you were just transitioning to the second slide, so.
Okay, thank you. Okay, so I'll just go over this slide again. So I'm going to go over the methodology for including prescription drugs on the eligibility list, and then I'm going to go section by section of the bill and talk about how we're interpreting and calculating thresholds. And then I'll go over the methodology for creating the prioritized shortlist, which should be more fresh in everyone's head since we just did this. And then feel free to interrupt me if you have any questions or want to see anything again, but we will also have time at the end for discussion and questions. Okay, so let's get into reviewing the methodologies for how we included the drugs on the eligibility list for affordability review. So this would be the first part of the review process, which is identifying eligible drugs for affordability review. So just a reminder, this is the part of the bill that states the different ways a drug can make the list. And I'm not going to read it all because I'll be going over it section by section, but it is here for reference. And then our data sources for pulling the data will be First Data Bank and Metaspan, which are two commercial drug pricing databases. So the first way a drug can make the eligibility list is to be a brand or biologic drug that has a WAC of $60,000 or more per year or a course of treatment lasting less than 1 year. So if you remember, our data source for this is specifically the dosing modules from FDB, which contains dosing data for drugs by age category. And then these are the terms that I'll be referring to when I talk about our course of treatment calculations. So as you remember, we're using the high dose, which is the dose that we'll be using in our formulas. And then, so for example, if someone is prescribed a dose of 5 milligrams of a drug, but it can also be prescribed as high as 10 milligrams a day for certain scenarios, then the high dose would be like 10 milligrams in this example, and that's what we would use in our calculations. And then the high duration of therapy means the high end in days of the recommended amount of time that the drug should be taken. So if like most people take it for like 10 days, but it can also be taken for as high as 21 days for certain conditions, we'll be using that 21 days for our formula. And then sometimes you might see like
Uh-oh. We lost you again, Kelly.
sorry, there's like a AI note taker that's waiting in the lobby. Are we supposed to like emit them or not?
No.
Yeah, they keep pinging, and so I just ignored it.
Okay.
Yeah, no, we'll leave AI note takers alone.
Okay. Yeah, so there could sometimes the high duration of therapy in days can show up as 0 in the data, but that just means it's a chronic medication, or there's no data available, but more likely it's a chronic medication. And then disease duration refers to the duration of the disease or health-related condition associated with that NDC. So that can be acute or chronic, or both acute and chronic. And then finally, there's like maintenance and single dose. So those are types of drug doses. So the maintenance dose is the amount of dose you need to take to achieve a steady concentration of the drug in your system. And the single dose is the like one-time dose you would take if it's not something you take regularly. And we're excluding vaccines and non-drug products from our course of treatment calculations. So these will not be making the eligibility list via the course of treatment threshold. So if you remember, we're using the generic name indicator from the FDB to identify brand name drugs. And as the name suggests, the GNI will use the drug's name to identify whether the drug is a brand name drug or not. And then we'll be using the FDA Purple Book, which is a database maintained by the FDA that contains information on all FDA-approved biological products to identify biologics. And this is a brief overview of the methodology that we will use to calculate the course of treatment. So first, we will deduplicate the data so that each NDC only has one dosing data record, because an NDC could have multiple dosing data for different age groups or different indications. And then once we get that one record per NDC, we will multiply that by the NDC's high dose, multiply the NDC's high dose by the high duration of therapy in days to get the number of units used in a year. And then we'll also do any unit conversions in this step if the high dose is in a different unit than the strength of the NDC. Like the high dose could be in milligrams, so the NDC is in grams, so we need to convert them to the same unit. And then after we do that, we multiply it by the NDC's WAC price to get the cost of a course of treatment per 1 year. And then, as I mentioned before, NDCs can have multiple records for like different age ranges and different indications. So we need to do this deduplication. So we choose one dose per NDC to use. So that means we're going to choose the dosing data for the highest age range, since adults will have a higher dose recommended than children. And we'll choose the chronic and maintenance dosing data if available, since that's the dose people will most likely be taking if they're using the drug for a year. And so I've shown this before, and this is an example of what dosing data would look like for a drug. So this is for an antibiotic Bactrim. So you can see there's like multiple dosing data for different ages and different dose types. And then after deduplication, we would only be keeping the record I highlighted here, since it's the dose for the highest age group, which is adults 18 to 110 years, and it's also the maintenance dose. So to put it into like a more visual way, the formula that we're using to calculate the course of treatment is high dose per day, converting that if necessary to the same units as the NDC strength, and then we divide that by the strength of the NDC, so we know like how much of the drug the person is taking per day. So if like the high dose is 10 milligrams and the NDC strength is 5 milligrams, we know that the person is taking 2 units of the NDC per day. And then next we multiply that by the days they should be taking the drug. And then we multiply that by the WAC unit price, and then we get the cost of a course of treatment. Okay, so this is example of how you would calculate the course of treatment, and this is for Erlita. This is new data that wasn't shown in previous presentations, and this is a brand name drug, and it's used to treat prostate cancer. It came onto the market in 2018, so it wouldn't have been eligible for when we did our when we pulled our list in 2023 because it wasn't on the market for 7 years yet at that point. So the most recent price for this drug at the time I made this presentation was $127.5 per unit set in January 2025. And I already deduplicated this dosage data, so our only row of data we're going to use for this NDC is what's shown here. And this is the maintenance dose for people aged 18 to 110 years old. And the high dose is 240 milligrams a day. And each tablet of this drug is 60 milligrams. So we don't need to do a unit conversion here. And then we see that the high duration of therapy in days indicates that the drug is taken daily. So plugging this into our formula, we have that high dose per day is 240 milligrams. The drug comes in 60 milligram tablets. So 240 divided by 60. No unit conversion needed, so the conversion factor is just 1. And then we multiply that by the high duration of therapy in days, which is 365. Multiply that by the WAC price, plug all those in, we get cost of a course of treatment for a year for Erlita is $186,000, $186,150. So that's definitely over the cost threshold of $60,000, and this drug would be on our 2026 list for eligible drugs for affordability review. All right, so again, feel free to stop me if you want me to go back or explain something again. So the next way a drug can make it onto our eligibility list, so we're getting into like the increases and stuff, is to have price increases that are 15% or more in a 12-month period or over 50% over 3 years. So for a drug to be included in the list in this section, I just mentioned before that they need to have that increase, and then that 12-month period that we're looking at where they need to have an increase is January 1st, 2025 to January 1st, 2026. And then we're going to look at their prices as of January 1st, 2026. So we're not going to like look at like what their price was like yesterday. So we're just setting that. We're going to look at all the prices as of January 1st, 2026 and not after that. Yeah, so they need to have a recent increase in that calendar year that I mentioned to make our list. And then in our last list we pulled in 2023, that time period was they needed to have an increase between January 1st, 2022 and January 1st, 2023. So like now the window has moved forward like 3 years or 2 years, 3 years. Okay. And then I'll be using the term current WAC to refer to the NDC's WAC unit price from that most recent price increase between January 1st, 2025 and January 1st, 2026. And for lack of better terminology, I'll use the term 1-year WAC to refer to the NDC's earliest WAC price in the immediately preceding 12-month period from the date the current WAC was set. And this next part might be a bit confusing because we haven't heard it in a while, but I'll be showing an example that will hopefully make this more clear and like jog your memory. The 12-month period will depend on the date of the NDC's current WAC. So if the current WAC is in like July 2025, then we'll look at what the NDC's price 12 months prior to that was. So like what it was as of July 2024. So if there were like 1 or more price increases before the most current one, between that period, we'd use the earliest increase, so the increase closest to July 2024. And if there are no price changes in that period, we would just use the NDC's price as of July 2024. So NDCs will have different 12-month periods we're looking at depending on when their current WAC was set, but that increase must happen between January 1st, 2025 and January 1st, 2026. So this is the formula for the 1-year price increase, and it's just the current unit price minus the 1-year unit price divided by the 1-year unit price. And this is, once again, an actual example of the newest data that we're going to use. And so this is data for Clomid, which is a drug used to treat infertility, and it's been on the market since 1999, so it's definitely been on the market for at least 7 years. And the current WAC unit price is from August 2025, and it's $11.50. So this meets our criteria of having that increase between January 1st, 2025 and January 1st, 2026. And so now we look back 12 months from August 1st, 2025 to August 1st, 2024, and there happen to be no increases in that time period. So we'll take its price as of August 1st, 2024. And then that price, which is our 1-year WAC unit price, is $7.86, which was set on July 3rd, 2024. And so plugging in these numbers into the formula, we get that the 1-year price increase for Clomid is 46.31%, and that's way over that 15% or more threshold. So Clomid would definitely make our list of eligible drugs this year. And it's also going to be a new addition to our eligibility list because it didn't have an increase in the time period we were looking at last time when we pulled our list. So yeah. Oops. Okay. And then moving on to the 3-year increase. So very similar, except we're now looking back 36 months instead of 12. So same idea. And then similar formula to the 1-year increase. It's just we're now plugging in that 3-year WAC price instead of the 1 year. And so this is an example for the 3-year, and this is also new data that I'm showing. So this is for Demerol, and this is a synthetic opioid medication. It came onto the market in 1990, so it's also been on the market for at least 7 years. It did have a price increase on January 1st, 2026, so it barely made it on our list. And that was to a WAC unit price of $21.85. So going back 36 months from the date of its price increase, which was on January 1st, 2026, we go back January 1st, 2023. And then what do you know? It happened to have a price increase on that very day. So we get that the price set on January 1st, 2023 is $3.13, and that'll be our 3-year WAC unit price. And then plugging in those numbers, we have that Demerol's price increased by 598% in a 3-year period, which is also well over the increased threshold of 50% or more stated in the bill. And this drug would also be a new addition to our eligible list because its price increase, it didn't increase in price enough to meet the threshold when we last pulled our list. Okay, so another way a drug can make it onto our list is if they are a biosimilar product that has an initial WAC cost that is not at least 15% lower than the reference biological product. And so we use FDB documentation to identify reference biologics in their biosimilars, and we'll calculate the increase in price using the price of the biosimilar's earliest listed WAC unit price, which I'll call the initial biosimilar WAC, and comparing it to the price of the reference biologic at the time of the biosimilar's earliest listed WAC unit price, and I'll call this the reference biologic WAC. And I keep saying earliest listed WAC unit price because Metaspan only contains like 12 price histories per NDC. So if the NDC has had more price changes than that, then the earliest one won't be like its actual initial price. So the formula used to calculate the increase is very similar to the ones I showed before. It's just we'd be using like the biosimilar and biologic prices instead of like the 1-year or 3-year WAC unit prices. Okay, so this is also new data, and this is how we would calculate the increase for a biosimilar. So this is data for Euflyma, which is a biosimilar to Humira, and these drugs are used to treat certain types of arthritis. And this drug entered the market in March 2002, but it's eligible for review because it's been on the market for more than 7 years. And then you see here that the initial WAC price was $6,576.5. They'll set on, sorry, I think I made a typo in this slide. It should have come into the market on March 2024, not the 2002. But it's still eligible for review because its reference biologic has been on the market for at least 7 years. So that initial WAC price was set on April 2024, 1 month after it came onto the market. And that $6,500 was the initial WAC price. And then at the time, the reference biologics WAC price was $3,461.31. So then if we plug that into our formula, we have that Euflyma's initial WAC price was 90% higher than its reference biologics price. So it was definitely not like 15% or more lower. So it would definitely make our list for this year. And then finally, a drug can make the eligibility list by being a generic drug with a WAC of $100 or more for a 30-day supply or less that has increased by 200% or more in the past 12 months. So I showed this before. We're using the generic name indicator to identify generic drugs as well, since you can tell from their name that they're generics. And then if the generic is like newer than 7 years, but the brand that it's based on has been on the market for at least 7 years, they'll also be included on our list. And so we're using a very similar deduplication algorithm to get the one record per NDC for the high dose to use for our calculation. So I'm not going to go over that again. But where this differs slightly is we're also going to calculate the increase. So kind of we're mixing the previous two methodologies. So we're calculating what it costs but for like a course of treatment, but then also the increase. So because it needs to meet both. And for the 200% or more increase, we're using the same method as like the 1 year increase, but now like the threshold is 200%, not 15. And so the formula is very similar to that. And then to calculate how much a 30-day supply costs, we're going to be looking at the high duration of therapy in days. So if the high duration of therapy in days is greater than or equal to 30 days, we're going to multiply the number of units used per day by 30 days. And then if the high duration of therapy in days is less than 30 days, we'll use the exact number of days that it is. So we're accounting for the cost of the 30-day supply that may be taken daily, but then we're also accounting for stuff like antibiotics that might not be taken chronically. And then this is just a visual representation of the formulas for each kind of calculation. So if the high duration of therapy in days is greater than or equal to 30, we multiply by 30, which is in purple. And then if it's less than 30 days, then we multiply by the exact amount of high duration of therapy in days. And this is an example from our 2023 data cycle. So you've seen this before. Also, this NEC is from a repackager, so it would not be on our list because we're supposed to exclude NECs from repackagers. But it'll still be good to go over an example with numbers. So this is for primidone, and it didn't have an increase in the time period that we're in our new time period that we're looking at. So it wouldn't be on our list, but it wouldn't be on our list anyway because it's from a repackager. But just for the sake of an example, this drug had an increase between January 1st, 2022 and January 1st, 2023. So it would have been on our list if it wasn't a repackager from last year. And then that newest price when I pulled it in 2023 was 24 cents. And that was set in 2022. And then it didn't have any price changes for a really long time. So it's like last price change was in 2010, which is 8 cents. This happened to be an exactly 200% increase. So it meets that first part of having a big enough increase to meet the threshold. And then multiplying the dose by the 30-day by the number of high duration of therapy in days to get the cost of a 30-day supply. We see that it is $288. So it increased by 200% over a 12-month period, and it also costs more than $100 for a 30-day supply. So it would be eligible for affordability review if it was not a repackaged NDC. But that would be like how we would calculate other data for other NDCs. Okay, next I'm going to go into like how we created the shortlist for affordability review. So we just did this, so hopefully I can go kind of fast.
Right.
Go ahead.
Yes, board members, any questions on that first part? I know it's a review, but, okay, just wanted to make sure before we jumped off the next cliff that we had the first one figured out, so. Okay, go ahead, Kelly, sorry.
No worries. All right. Okay, yeah, so when we create the shortlist for affordability review, this would be like the second part of our affordability review process where we're selecting drugs for affordability review. And then this is a part of the bill that says that what the board shall consider, and then the board can also and has also come up with other measures they want to look at, and the board can choose up to 24 drugs per year. And these are the data sources that we're using for our affordability review. So we have the all payers claim database, we have manufacturer data, PBM, prescription benefit manager data, and then once again, our commercial drug pricing database data. So as the bill mentions, when choosing prescription drugs for affordability review, the board will look at those 3 required measures from the bill, which I color coded in blue. And then the brown measures are the ones that were proposed by the board. And then I also have a little graph icon on 4 of the measures, and those signify that those are quantitative data measures or data measures that can be measured, counted, or expressed as a number. And they will also be the data measures used in our ranking and weighting methodology, which I'll go over really quickly in our next slides. And then this is our methodology that we use to create the 2025 shortlist, but going forward with the 2026 list based on our discussion from the last, or was it the November board meeting, we'll be changing our methodology slightly, and I'll mention this in our upcoming slides. So this is more of a refresher on what we did for this cycle, but going forward, it might be slightly different. Okay, so first what we did was we separated the eligible NDCs into specialty and non-specialty drugs. So prescription drugs that are biologics and biosimilars, except for those reclassified as biologics under the Biologics Price Competition and Innovation Act, were considered specialty. That means they require special storage, handling, administration, or monitoring. And brands and generics were considered non-specialty. And then after we separated our drugs by specialty and non-specialty, we aggregated their data by labeler code and generic name. And the goal of this was to aggregate drugs with the same ingredients from the same manufacturer or distributor. But in our November board meeting, there was discussion that going forward, we want to aggregate the drugs by generic name only when creating our shortlist. So this is what we plan on doing in this upcoming data cycle. So we're going to aggregate by generic name regardless of manufacturer. So after we do that, the next step is to rank and weight the data and calculate the weighted rank for each labeler code and generic name. So we do that so we can create our shortlist. So to rank the data, we sorted each quantitative data measure in descending order and assigned rankings. So for example, here, we sorted each quantitative measure in descending order and assigned a rank. And usually like a labeler code and generic name might not have the highest ranks across the board for everything. So it might rank highly in one measure and not as high in another. And that's what's happening here in this fake data. And then in cases where rankings are tied, we use the average ranking method to break the ties. So for example, in these 2 circled labeler code and generic names, they both had a total paid amount of 12, but they're ranked in positions 3 and 4, which is not correct since they have the same total paid amount. So if we use the average ranking method to break the ties, the final total paid amount rank is the average of the rankings. So that would be the sum of the rankings 3 and 4, which is 7, divided by the number of tied labeler code and generic names, which is just 2 in our case. So 7 divided by 2 is 3.5. So if we use that average ranking tiebreaker method here, both of these labeler code and generic names would have a ranking of 3.5. So that's what we used if there are any ties in the rankings. And we also had weights, which were created when the board members did an exercise to like assign points to the quantitative data measures based on how important they thought the measure was. So these were the results from that exercise, and what I circled here are the weights that resulted from that. And so this is the formula used to calculate the weighted rank for each labeler code and generic name. And then after we did this calculation, the top 25 lowest weighted ranks, the top 25 NDCs with the lowest weighted ranks for specialty and non-specialty labeler, sorry, not NDCs, the top 25 labeler code and generic names with the lowest weighted ranks for specialty and non-specialty made up the 2 shortlists. So the weighted rank is basically the sum of the rank of the data measures multiplied by their respective weights. And then this is the same formula, but it has the actual weights plugged in. And then this is an example from my previous presentation in 2023, or it's using 2023 data, so it's not new data. But nonetheless, we can see how like the data is actually plugged in here. So this is for the drug fingolimod hydrochloride for labeler code 00078. And so plugging the formulas, plugging the numbers into the formula, we can see that we plug in the ranks, the respective ranks for each data measure, and we can see that this drug has pretty like varied ranks. So some are lower, some are higher, but nonetheless, you plug it in and then you multiply that by the weight, and then you get that the weighted rank for this drug is 7.17. And then so basically we do this for like every labeler code and generic name, and then we rank the weighted ranks, if you will. And then once we do that, we can select the top 25 specialty and non-specialty labeler code and generic names with the lowest weighted ranks, and then like those turn into our 2 shortlists. And then once we create the shortlist, the board will look at the weighted rank as well as all the data measures, both quantitative and non-quantitative, to select the drugs they want to review. Okay, and these are some limitations for our methodologies in general. So this is like going back to the first part of my presentation, but I still think it's important to point out. So when we're doing like the WAC, calculating like the increases with the WAC cost, we're not making any adjustments for price inflation. And then also our data sources, as I mentioned before, might not contain the complete price history for NDCs if they like change too many times. And then finally, we're using the high dose data to calculate the course of treatment, and this might not reflect the dosing data that most people are prescribed. So our next steps will be to pull the 2026 eligibility drug list and then create the affordability review shortlist from that list. Okay, I know that was like a lot and super fast. So yeah, any questions, or you want me to go back to anything? Let me know.
I think that all looks really good. Thanks, Kelly. Appreciate the summary.
There doesn't appear to be any questions here in Olympia. So
Okay. Yeah, so I think, again, just something to, as a refresher here for what's coming up in June. So that way, when we have the drug list, again, we know how it got here, what we're looking at, how the selection criteria, was made. And then so I think some of the other questions around this that we were chatting about a little bit earlier, that we should start thinking about, or maybe we can discuss a little bit if you want, is so we selected 2 drugs this last go around. Start thinking, or any thoughts on how many drugs we want for the next go round. And then I know we also had selected 2 additional ones that, we just didn't get to. And so, do we want to push those forward, or, I know Doug, you had thoughts of, hey, let's just start with the fresh list with the fresh data, and kind of pick from the top from there. So I think it's just things to ponder as we prep for this upcoming new list. And I think for us, starting small has served well, just with figuring out the kinks and figuring out the data. I think was a good strategy to help us not be overwhelmed as we were trying to put together all the pieces of the puzzle for the first time. So yeah, those are just some other points of consideration that as we're coming up on this June drug list, things for us to consider as we are getting ready for that. So thoughts, questions?
Yeah, I'll just add, I agree with, excuse me, Mike summarized it well there, but I think that the information that we're going to get from the new eligibility list is going to be more up to date and basically reflect a more accurate picture or depict a more accurate picture of what we of the current situation in Washington with regard to affordability of these drugs. And so I'm in favor of using the most up to date data as possible and in all of our subsequent decisions.
Yeah, that certainly seems reasonable. I see Eileen shaking her head, yes.
Yes, I would agree. I think that, we want to look at what's egregious this year, not what's egregious from the years past.
Yep.
Okay. Okey doke.
Ready to go on?
Yeah, so I think with that, we're ready for our executive closed session. So we can maybe put this on pause here, Simon. And
Well, before we do that, can the chair just sort of read the purpose of the executive session and then also the time when we
Do I
plan to
have
come
that?
back and we need extra time, we come back to public session to tell the public.
Is there something here in,
If not, I will do.
I can certainly come over there and
Oh, yeah.
make it easier.
We're-
Oh my,
It
okay.
would be, sorry, this is
All right.
pursuant to,
How much do you want me to read?
well, just, yeah, so pursuant to RCW 4230-110,
Start.
and then
Just here,
little
what-
p,
Okay.
we'll be going into executive session.
All right.
And, just sort of highlighted the part, sort of showing your obligation to say the reason for executive session, and I will return to public session.
Okay.
But yeah, just.
So the reason for us to go into executive session is to consider proprietary or confidential data collected or analyzed pursuant to Chapter 70, 405 RCW. Before convening an executive session, the presiding officer of a governing body shall publicly announce for the purpose for excluding the public from the meeting place and the time when the executive session will be concluded.
Okay, so what is the time when we're anticipating this to be concluded? And so that the public knows when to come back? And we can always come back to the public
Okay.
session and say, hey, we need more time. We'll
Okay.
be back at,
maybe let's start with a half hour
Okay.
and then we can
We'll
10
start.
maybe? Yeah, 10 o'clock.
Yeah, let's say we'll try to run it till 10, or we'll run
Okay.
it till 10 and then regroup,
Okay,
and we'll have to ask for more time if we
Yeah.
need it. Does that sound reasonable?
okay.
Okay.
Thank
All
you.
right.
Yes, we'll
Thank you.
come get you.
So you
Will we
wait
be
out
will we be in the
lobby.
lobby?
Yeah.
Can we get you in the lobby? Okay, thank you.
Okay.
Yeah,
All right.
so let's go to
This
executive
one.
session.
Okay.
Yes, so
So are we
Can we
supposed to-
hold on to the other meeting link?
Okay, we'll jump. Thanks.
Okay.
Let me know when we're ready. We got it? Okay. So those folks that are online, we are going to have to extend our executive session for at least another half an hour. So we will be regrouping at 10:30. So thank you for your patience. Okay. Well, I want to take the opportunity to have you meet Ryan Moran. And Ryan, gosh, started in the middle of August as the new Healthcare Authority Director. So I'm going to invite him today. So
Yeah, I am so grateful to be here. Thank you, Chair Vlad. And I just will say, like in a very public way, super grateful for Marianne for her service. Obviously, long before becoming interim director last year, where she served for the state, but also the enormous help she was in the transition process for me personally. So it's a treat to have you back on the board. I know you had to take a step away, and now you're back in the chair seat. But we're really happy to have you. And I think, and I also want to thank the staff and the team, Simon, Mike, Ryan, for your work on getting the PDAP started. I really reached out since joining in August to say, really interested in this body of work and this group's work. I'm thrilled that this is part of the purview of the Healthcare Authority, and there's a few reasons I'm hoping to demonstrate that in a very real, tangible ways about the direction of the Healthcare Authority and the overall thinking of the challenges that we face in healthcare and just how important this work is in that regard too. I'll just say a little bit about me. I've had an opportunity to meet a lot of people who are on the board. I see Ronnie, I see Eileen Cody, who have had the chance to interact with as well. But my background's coming from the state of Maryland, where I was the state of Maryland's Medicaid director. And in that realm, one of the states that I know that the board looks to in terms of learnings and best practices or things to share ideas with is the state of Maryland. So the Medicaid program that was there, we did not, if you will, have direct purview over the prescription drug affordability that the Healthcare Authority has, but we were obviously, because of Medicaid, a very close partner in the work that they were doing. And so worked very closely with colleagues there in Maryland to support that work, really centering affordability around for individuals across the state. So I come from that perspective of really being interested, curious, and a partner in this particular work. And I'm thrilled that this is part of the body of the Healthcare Authority. There are two things I want to say to the board and sort of an introduction and also the next direction where I think there's a sync here. The first is for the authority as we navigate the complexities that we have from our healthcare environment, thinking about the three pillars that we have of Medicaid, PEV, vision of behavioral health recovery, and then opportunities to support those particular work with PDAP, with the cost board, with our value-based purchasing work, with rural transformation. Our focus is really on three priority areas for the future that you will hear me and other members of our leadership talk about. But that is the first and foremost in this time, how can we as an agency be responsive to the needs of Washingtonians? And there are 4 key areas of focus in that bucket. And that is number one, coverage. We know that the authority and the programs that it operates has significant challenges of changes to federal programs that threaten the continuity of coverage, particularly at the Medicaid, but also our federal financing program in any area across the Healthcare Authority and across the state. So coverage. Coverage means also sustainability of our delivery system. And so we at the state play a very important role of designing the programs and policies that, yes, the folks from the federal government will have to go through, but we can play an important role trying to ensure that the coverage is mitigated as much as possible, and then that obviously leads to the delivery system being sustained as much as possible as it can in this environment. The third area in that bucket is partner accountability. And so the authority is home to some of the state's largest contracts, managed care organizations, carriers on the PEB and SEB side, contractors on our behavioral health division recovery. I take very strongly the responsibility of state government to be the health strategist and to hold those partners accountable to ensure that we are centering the lives of the people that we serve. And the last, which is the direct correlation with the work of the prescription drug affordability, is cost and affordability. Over the last 6-8 months, really since the discussion around HR1, the national debate in healthcare is all around cost and affordability. That increased in its elevation with the sunset of the enhanced premium tax credits for folks seeking coverage on the individual individual market, which has some direct connection with our work with the authority as well. But we know that the other pressures that exist in the healthcare environment continue to put a significant pressure on cost, and how that impacts Washingtonians specifically at their particular level is of utmost importance for us to begin to think about how do we use the assets that we have, like the prescription drug affordability, to impact that on a daily basis. The other two areas I'll focus less on, but just to give you a sense, is the other two focus. The second one would be closing gaps in health disparities and advancing health equity. So some things that are very important for us as the authority moves forward in the future is advancing investments in primary care, continuing Washington's work in the integration of behavioral health and physical care, and investing in our behavioral health, specifically our community behavioral health system delivery of care. Maternal child health, we have a unique opportunity in our state with the Rural Transformation Grant to advance rural health. And so our teams across the Department of Health and Department of Social and Health Services are working on that opportunity. And then the final area of focus for us is strengthening agency operations at the Healthcare Authority. And you might say from an agency head, that's really odd because that's your job as a person who's overseeing the agency. But we call it out as a priority because today's environment, in the face of the dynamic around us, it's all about the basics. It's all about your eligibility systems. It's all about, can providers get a hold of you to register to become a provider within your PEB&SEB or your Medicaid networks. Even the discussion around fraud, waste, and abuse that is centered in the national debate right now. Program integrity isn't new for federal financing or programs. We have always cared about program integrity from a state service perspective. And in fact, there are very strict federal guidelines that guide us in these regards in thinking about the use and stewardship of public dollars. But those operations for an agency like ours are really important so that we can get the basics right in terms of what we navigate forward. So we're very focused on people, process, and systems at the agency at the moment. Plus, we can't do this work alone at the authority. We have to work across all of our state agencies and be in silo busting work with the SHS, with the Department of Health, with the Benefit Exchange, with the Department of Children, Youth, and Families. And I'm fortunate and have the pleasure to work with those colleagues and agencies to be able to do that in that work. So that leads me to sort of a culmination and a summary of if that is the vision, direction, and the strategy. This particular work, as you can see and as I've outlined, really plays an important role. I know I've talked to Mike and Brian and Simon about wanting to, as you move into the board's authorities and what you're talking about in terms of upper payment limits for 2027 and the tools that you've been assessing for the past couple of years since the board's inception, is elevating this particular work as we center healthcare costs and affordability. So that's a key priority and area of focus for us. And the last thing that I would mention is I see some direct connections between this board's work of prescription drug affordability and the overall work that the Cost Board and Cost Transparency Board is doing at the authority as well. Their three areas of focus, which are very much in alignment with some of our priorities, include investment and thinking about strategies of investment into primary care or strategies to improve primary care access into the future. You know, primary care plays an important role trying to reduce the cost curve for healthcare. Second is looking at expenditures, the Cost Board looking at healthcare expenditures, which has been traditionally their particular role over the last few years. This year, the Cost Board is electing, which has come up in the data calls from carriers in the past, of the increasing costs of pharmaceuticals. So obviously that's a direct connection with this board's particular work. And so we will need to work collaboratively together. And then secondly and thirdly, market oversight, mergers, acquisitions, consolidation. What does that do to the overall dollar and healthcare spend within the state of Washington? So if that's their three priorities, I very much view and want to ensure that this particular work culminates with their work so that as we move into the next biennium, you begin to think about decisions at the board, your own discernments, that the work of cost and affordability for everyday Washingtonians is centered in that. I'm grateful for your service to the board, for board members who are serving and for being on the forefront nationally of getting one of the first PDABs up and running. And I know we have Chair Eileen Cody to thank for that from her time in the legislature. And I'm looking forward to staying in tune and really partnering with you to advance and elevate this work in the future. So I thank you for letting the chair crash this meeting. I wanted to come and talk, but I really didn't want to come and talk and genuinely say this body of work has renewed focus for the agency in terms of our vision and direction as we move to the future. Any questions? Yeah.
Folks here at the board, any questions? Folks on the screen? Any comments, questions?
Great to meet you, and thanks for kind of coming here and sharing your philosophy and your guidance. I think that's really helpful for us as we kind of form decisions in this board as well. So thanks.
Yeah, same. No questions for me, but it's nice to meet you and appreciate the the introduction.
Eileen, anything? See Eileen. Okay.
Yeah. In Mexico, so
Yeah.
enjoyed vacation.
Any questions from staff?
Oh, I appreciate, taking the time to come down here. And, yeah, we're always looking at ways to try and do things better and collaborate. As this is all new, we're kind of figuring it out as we go. And yeah, we have some other partners in other states, which is definitely helpful to collaborate with. But, as much as we can also build upon the resources and things that we have here internally, have access to. I think that'll also be good. So.
Well, we really appreciate Wayne coming and hope that you'll stop in when we have other meetings, so we get him on the calendar for future meetings.
That's my plan.
Great.
Thanks, Ryan.
Yep. Anything else? Okay.
Great. I'll let you get back to work.
And let you get back to work.
Yes. Mutual.
Take care.
Thank you.
So let's see, where we want to go next. We want to.
So I think just to kind of have some continuity of operations here, maybe we can go to the upper payment limit presentation. We still have a little bit more to discuss in our closed session with the board, but we can kind of put that last piece of that maybe towards the end of the meeting, just so people aren't waiting around on us for too long. So Eileen, Mary Ann, does that sound
Sounds perfect.
good? Okay.
Turn it over to Simon.
Sounds good to me. I just want to see if we can get Eileen on before I start. Sent over another link, but maybe we just give it a few minutes. See if we can get her on.
Well, while we're waiting, can I just clarify where we are in the agenda? I think we've kind of jumped around from what one that I received.
Mike and I.
What do we still have left? What do we still have left to do?
So go ahead, Mike.
So we got our UPL presentation we have to do, and then we got public comment, and then we just need to finish our executive session.
Yeah.
So I think if we can do the UPL here, and then do we want to do public comment?
Let's do public comment, and then we can go back to the executive session.
Is that okay?
Folks want to comment, they don't have to wait.
Yeah.
Does that work okay, Michael? Okay.
Yeah, it's gonna sound silly at the time after we sort of close out the public session of the meeting. We are still gavel back in at the end of the executive session. The expectation that everyone in the Zoom room, physical room, is to say adjourned.
We'll adjourn the meeting and then we'll back up.
Okay.
Is that what it sounds
Yeah.
like? Okay. All right. Well, then let's go ahead. Simon.
Should we wait if Eileen able to join or just?
Why don't we just go ahead and start? She can, hopefully she'll pop in.
Here, I found Eileen real quick. One sec. Hey, Eileen, with the HCA director that popped in, we moved back into our regular meeting. Can you get back into that meeting? You can't get in? Where's your sound? Oh, give me one second. My sound here. Sorry, what was that?
Did the other, I just sent a couple more emails to her. Did either of
Simon
those
just sent another email or two. See if those work. Okay. Yeah, we'll wait for you over there. Joys of technology. Okay, maybe if she can't do that, just leave her on this one.
Potentially.
Can't we? Yeah, we can't
Okay,
get, yeah. But she can listen, she can hear us.
leave that as a backup.
Links.
She just emailed me same problem. She'll wait for the executive session.
Okay, well, I'll just I'll try this and we'll see if there's any sort of echoes. Tell her to go back on the other link. Eileen? Hear me? Okay, well, let's get started and I'll see if I can
If we can pull her in.
figure out on this end what's going on.
Well, Simon, I'll be presenting on just an intro to upper payment limit methodologies, and to put this in context, as we're doing the affordability review, at the end, one of the options is to put in an upper payment limit on the drugs that are deemed to be leading to excess costs. But the way that you implement an upper payment limit, there are a lot of different approaches that you can take to getting to that final number. And for us, what we'll want to do is make a decision of how do we write our administrative codes, the WAC, to be able to reflect whatever methodology we choose, and at the same time retain some flexibility so that we can use the right metrics and the right approach for each drug. So in this presentation, I'll go over what's laid out in the legislation in terms of what we need to do for an upper payment limit and how we're restricted. And then I'll go into the timing of how this will all work. And then finally lay out just a high level of different methodologies that are out there for setting an upper payment limit. Then we can dive deeper into those in future meetings or kind of think through those at a deeper level later. So background, and a lot of this will be familiar just from the legislation and from our conversations. What I wanted to do was to pull the relevant sections of the legislation into this PowerPoint so that you have just one reference point, and then organize it just so it makes more sense thematically. So each year we can set an upper payment limit on up to 12 drugs. Obviously, we'll be starting lower and way up. There are certain types of requirements that we have to do and certain prohibitions on what we can't do when we set this methodology. And as I said before, we set an upper payment limit. Like for instance, Colorado, they set a certain price for a certain drug. We'll want a methodology of how we get to that price. Something that's defensible and follows certain logic. In terms of legislative requirements, there are certain things that we must take into consideration. So the cost of administering the drug, the cost of delivering the drug to patients, the status of the drug on a drug shortage list, and then other relevant administrative administrative costs related to the production and delivery of the drug. Then process-wise, we'll need to post notice of it, and then down the road, we'll need to monitor the supply of drugs in the state. So that's an important bullet because a lot of the comments we receive are, will this make it tough for patients to access the drug? And that's just something to flag that down the road that's something we'll be monitoring. From the prohibitions, limitations on how we can put together the UPL, not use quality adjusted life year standard that takes into account the patient's age or the severity of illness or the disability when we identify subpopulations. And so it's just some of the methodologies that are out there incorporate qualities in different ways. And we'll just want to thread that needle of how we're using that. We cannot put in place a UPL before January 1st. And then here's where we get in. I've got a chart later that makes this, I think hopefully makes a little more sense, but there's some funny dates. We can't establish it before January 1st, 2027. It can't go into effect until at least 90 days after the next regular legislative session. And then the effective date must be at least 6 months after we adopt the UPL. Doug, I see your
Great question. Yep. So the use of quality is basically the first bullet there. Is that referring to the determination of unaffordability or the determination of the UPL level? Or both?
So in this instance, it's referring to the UPL. This is pulled out of the part of the legislation regarding the UPL. I'd have to go back and check if it also applies to the.
Yeah, I guess I was just trying to remember if this also applied for the determination of affordability.
Yeah, I think that's correct. We can determine the affordability before this, but this is specifically for setting up the UPL.
So here it's smallish print, but I tried to just call out what those last three bullets were saying around the timing. And so we can announce the UPL sometime after January 1st, 2027, but ideally we'll announce it before the start of the legislative session in 2027. So that's, I believe the legislative session begins on the 11th of January. And so from the 1st to the 10th, we can announce, and that way we can potentially have a UPL in effect with in 2027. And it would be at least 6 months after we announce. So starting on July 10th at the latest, and then 90 days after the legislative session ends, so July 27th or July 25th. So really, if the earliest so we can put in place a UPL that has an effective date in 2027 would be announcing in very early January and having it effective in late July. Does that make sense? Any questions? The caveat here is that the UPL goes into effect for purchases, contracts, and plans that are issued on or renewed after the effective date. And so while it may go into effect July 25th, 2027, it'll really be subject, those plans that'll be subject to the UPL will be the ones that are issued or renewed on or after that date.
And I'm assuming that we are, it's that they'll actually get out of town on time, the legislature, so will it get pushed out?
That's just, yeah.
If they,
I think it says regular session, so if there is an
Okay, so we
extended
can-
session, that
be
wouldn't
okay.
impact it.
Okay.
Just a quick question. How often are these contracts renewed? Are they annually? Or just depends?
Yeah, so that was something that we had discussed, that probably a lot of the plans, the renewal date will be January 1st, but there'll be some that'll be mid-year. And so realistically, our assumption is that many of the plans that would be subject to the UPL wouldn't feel an impact. If we were to announce it in January of 2027, they wouldn't feel an impact until January of 2028.
the next.
But this timeline is important to know just because if we miss that window in January, then we fall, another year later. And we've discussed this before in terms of what entities are covered. Again, there's some technicalities here, but it's all purchases of the drug by an entity and reimbursements for a claim for the drug for health carriers or health plan offered under Chapter 4105 CW. And it's really those plans that are governed by the Office of the Insurance Commissioner, certain state plans, and then the kind of national ERISA plans can opt in if they'd like to. And then also the federal plans aren't subject, obviously, for reasons. And I won't go into too much detail here, but I did want to put it in the slideshow just so that people have all of these rules in one place. But once we do announce a UPL and it goes into effect, there are processes for manufacturers to appeal that decision. And we can cross that bridge once we get there. That's the first half, and I'll just take a quick pause for questions before moving into just an outline of the different methodologies we use for UPL. Seeing none, I'll charge ahead. So as I mentioned, there are different ways that you can put together a methodology for how to institute a UPL. And a lot of this is drawn from a white paper that Portal put out that I've shared with all of you. And I would dive into that if you want further details or examples. They do a really good job. We also looked and just tried to see if there are other methods out there, but really Portal did a good job of collating everything into one spot. The three big categories are reference pricing, and there are a few subcategories there, which we'll dive into. Looking at the net price, and then setting a UPL based off of certain budgetary thresholds. So reference-based pricing, there are a few different approaches. One is to do a therapeutic reference price, and so that's taking the drug and trying to ascribe a price and value based off of how it compares to alternatives in the market. And then the other approach is external reference pricing. So benchmarking against international prices or other states, or against federal prices like the Medicare maximum fair price, which we discussed, or the VA's federal supply schedule, which has a formula that they use. Diving into each of those, therapeutic reference pricing, like I said, what you essentially do is you take the drug and you look at the therapeutic alternatives and you compare based off of the cost and the efficacy. Where do you think this should be? Is it priced too high for its efficacy? Is it priced too low? So the strengths are it's kind of reflective of its market value and its therapeutic value. And if you have the data, it's a fairly straightforward analysis. Limitations. One, if you have all the alternatives of high prices, then everything is just going to be inflated. If it's difficult to identify therapeutic alternatives for the drug, then it may be tough. Finding the data on those drugs as well may be tough. And there may also be implications for where the drug goes in formulary placement. And those are decisions that are made by the entities, but then we could have a knock-on effect on. In terms of external reference prices, so one approach is looking at international prices, so comparator countries. Often you'll see looking at OECD data, what are the other developed countries doing? And then you set a price that's either the lowest price, the most favored nation, or an average or a weighted average from those countries. Pros, obvious, it leverages lower international prices, and it's a very simple analysis. The cons, one is that they may be using metrics that we're barred from using in their analyses. And two, there may be information that's confidential and what they're getting and that we won't be able to access. So, another external reference price that we could use is the Medicare maximum fair price. And this is the one that, as I'll mention later, the other states have really been relying on. And so, as you know, they set a ceiling on the drug price based off of either the weighted average net price of the drug under Part D or a percentage of the non-federal average manufacturer price. It's the pros of this. It leverages the power of Medicare. It's pretty understandable and tested formula, and it's been used by the other states as well. And so we'll be able to see what challenges they face from the manufacturers. The cons, there may be differences in what drugs we're reviewing versus what Medicare is negotiating. And I think as our list of drugs expands, that's going to be a bigger issue. And then finally, in terms of reference pricing, using the VA or federal supply schedule pricing. So this is calculated, similarly, they use the non-federal average manufacturer price, but they have a slightly different formula. Again, it uses this price negotiation regime that the federal government is using, and kind of a much simpler analysis than trying to derive one on our own. But we may face confidentiality issues, and again, the drugs may be different lists. So the second and third approach are, have less sub-bullets, so they'll be a little bit quicker. But the second approach is to use a net price, and we were just discussing some elements of the difficulties of this, but setting a UPL based on the drug's average net price after rebates and discounts, it ensures that rebates and discounts are reflected in the patient out-of-pocket costs, and so that's big because obviously those are kind of big determinations of how a drug is priced in the market. However, the con is something that we've discussed, I think, in a lot of meetings. It's tough to find that information or to get access to it. It may be restricted or confidential. Then the final approach is using a budgetary approach, so setting a budgetary threshold and trying to meet that. One version of that is to use a premium growth threshold, and so try and determine the impact of a drug's price on the insurance premium, and then use a UPL to limit that premium growth. It's nice because you can tie the savings directly to the patient premium reductions, and one of our goals is to tie the savings directly back to the patients. The con, though, is it's a more difficult analysis to try and tease out what one drug's impact is on broader premiums. And then just to compare against the other states, so Colorado, as Mike mentioned, they announced their UPL on Enroll, and that's anchored to the Medicare maximum fair price. Maryland is working on their methodologies, and what they're putting into their policies is really like a broad-based approach where they can use the methodology that makes sense for each drug. But in the first few UPLs that they're setting up for Jardiance and Farxiga, they are using the Medicare maximum fair price. So that's just a data point to have in mind. And then kind of a simple slide, but our recommendation is to follow along with what Maryland has done, which is to really try and have a methodology that's broad enough that we can tailor it for each drug and not be tied to one approach. Logistically, how that would work is the next step is working on writing the Washington Administrative Code, and we work with our team and work with Michael Tunick on the actual language. Have it specific enough that it matches everything that we need to do with the legislature and the legislation, and then have it outline some potential options for methodologies that we can use. And then once we've selected a drug for a UPL and we want it put in place, a specific UPL, with that one, we would put in place a policy drawing on that WAC and specify which methodology we're going to use. That's the initial recommendation, but open to conversation.
Any questions?
Thanks, Simon. That was yeah, that was helpful. And I just want to say I agree with the recommendation that you gave.
Any questions from board members?
Sorry, can you just go back to the premium growth? I just didn't quite understand it. Maybe you could explain it a little. So the idea is, can you just run through this one more time? I just don't think I caught it.
Yeah, so the idea would be to look, and I think in our case, identifying a certain population or certain group of plans and say, for these plans that we have the data on, in what is the impact of this drug spend on patient premiums? And if we were to set the UPL at a certain cost, would that bring down the premiums by a certain
Right. So I think in this, we would be using like a budget impact model in order to look at where the costs are, where the utilization is, and then the reimbursement, rebates, things like that, and then be able to determine if the board wants to address the excess cost because it's unaffordable to the healthcare system over a 10-year period. This approach number 3 tends to address costs, excess costs that are attributable to that. And you can say, we feel that this upper payment limit should be set at a price such that it controls the premiums and therefore ensures a sustainable healthcare system for public and private payers.
Gotcha. So you, oh, go ahead.
I was just going to ask, are you looking across all of the like PEP, Medicaid, or
Not
not
Medicaid.
not Medicaid? You're just going to do PEP,
Yeah, it would be HEPSEP and other public.
and other public they'd have access to. Okay.
Yep, and private payers and ERISA plans that choose to want to participate. I imagine some ERISA plans would want to.
Okay, thanks.
Good questions.
Yeah, which one other thing I wanted to mention about the recommendation regarding flexibility. I think that, like I said, I agree with it. We should do the best we can for each drug, given that we're going to have different data inputs to each drug's UPL decision. So I definitely agree with it. But I also think that the flexible approach could also be interpreted as arbitrary. We're sort of just picking and choosing arbitrarily. And so we need to be careful about clearly justifying the choice that we make for each drug towards some end. And I guess we would use the language in the statute at the end. But just wanted to note that we can't look arbitrary.
Yeah, and on that, the board would be able to discuss it and be able to vote and agree to a consensus on which type of these approaches may be appropriate for different drugs. But given that you're looking at brands, biologics, generics, you're looking at many different disease states and very different costs and budget impacts, it makes sense, to be able to have different tools, instead of just one tool to address
Totally.
every issue that comes up.
Well, it's like what Maryland did with it's like some drugs you have the Medicare MFP, which is an incredible resource. Like that, they've done all that research and they have incredible resources to arrive at that number that we don't have. So it's like if we have that information from them, I think it'd be foolish to not use it, but we don't always have that information. So I think we have to be flexible in that respect.
Simon, are you saying that these methods, that whatever we decide, and it sounds like if we can do the flexibility, then it needs to be written into rules? Is it okay? And it's not currently. We just okay.
Yeah, so that's one of the things that's actually in the legislation outlined. We need to create the rules around upper payment. So that's kind of, because the rulemaking process takes so long, we need to start now. So even though it's like, okay, we have 2027 till we can set upper payment limits, then obviously Simon's timeline, they don't actually become effective until 6 months later. We need to start looking at these things now in terms of how are we going to create these rules, how are we going to set up these methodologies, create these policies. So one of our goals here is for our next meeting in May to come back with, okay, here's some proposed language for the rule. Here's some ways that we're thinking that we could flesh out the methodologies below some of these. Look at establishing those policies. This is kind of the introduction to here are some of our possibilities. Do you like them? And if so, let's go forth and start seeing what we can do to standardize it into policy. So,
Other questions, comments? Right. Well, I think it's time for us to go ahead and move into public comment? Looks like, oh, Daria. Daria, go ahead.
Can't hear you.
Thank you. Sorry, switching between Zoom and Teams. My microphone is always on the wrong microphone. Thank you, board and chair and board members. For the record, Daria McGrew on behalf of Pharma. Thank you for the discussion today and the review of the methods from last year and starting the process of your UPL regs. We have not had a time to prepare a written letter for these meeting materials, but we will follow up with additional comments on all of this. Appreciate the lead time the board is taking to set this up. There's a large amount of work involved in this. As you note in the slide deck, there are a lot of pros and cons for each of the potential methods you have touched on. We will provide additional thoughts on each of those. Setting that aside, I want to flag that setting a price threshold is just one tiny step in a UPL that doesn't scratch the surface of how a state could actually operationalize a UPL. I urge the board and HCA to also in this process consider how any such approach could possibly be implemented at the state level. You must consider how different markets operate in significantly different ways. For example, the MFP rate that you mentioned is specific to Medicare with the goal of saving money for the federal government. MFP does not reduce patient out-of-pocket costs, and it is being operationalized through a retrospective rebate. This only works because CMS is both the payer and the regulator. They have the data. They are paying a large amount of money to a TPA to analyze the data and determine how much the manufacturer pays in rebate on the back end. And it is unclear how any state could implement that in the commercial market, given the differences between state regulators and CMS. One additional resource you could consider looking at as board members is the Oregon UPL study that was done a year or two ago that discusses quite in detail much of the complexity involved in each of these methods. In the Oregon UPL paper does go into additional state data needed and additional rulemaking authority that would be needed for each of these various methods. So as I said, we will continue to engage throughout this year as you move forward and provide additional comments on your process. Thank you for your time.
Thank you. Any other comments?
You've noticed beforehand, Tiffany Westridge was going to speak, but I don't see.
So we did get a couple of letters we forwarded to the board, and one of those was from Tiffany. So take a look and read through that, as well as all of the letters, because they also discussed some of the same or similar concerns around PPLs that Daria just expressed.
Let me see if maybe I upgrade Tiffany to panelist. That allows her to speak, but that's fine.
There, Tiffany. Okay. Well, that's it for the main presentations that we had. Is she there?
I'm here.
Okay.
All right, great. Thank you so much for the opportunity. My name is Tiffany Westridge Robertson, and I am speaking today on behalf of the Ensuring Access Through Collaborative Health and Coordinating Patient Inclusion Council, or the PIC. I'm also a person living with autoimmune disease, treated by a couple of the drugs under review here this year. And I wanted to actually talk, it's a little different than what we submitted for the coalition letter. And that is specifically to talk about as the PDAB begins its initial reviews, that making sure that the patient-facing data collection and the concerns that our coalition, me included, have been raising in respect to a need to revise what's currently out in the patient surveys. As published, they do not reflect meaningful incorporation of public comments. They will, so for those reasons, we would like to see those adjusted. This does matter because proper question design is essential for usable analysis. This is not theoretical. Our coalition, including myself, who has a strong background in research, have been working on prescription drug affordability review surveys based on since 2023, when the Colorado PDAB survey showed that poor question design prevented fully truthful responses from patients and resulted in misleading analysis. Our coalition has worked for the last 18 months to identify the right questions to ask in a multi-phase research project, which I have shared the pilot with this PDAB in August of last year. I was told by the staff that we would be referred to as collaborators when it was time to write the patient survey, which we were not. I did, however, participate in the September 18th request of a public review and submitted substantial revisions, only to have one minor suggestion adopted. When I asked staff why, I was told that the survey was based on what the board and the staff and the stakeholder council wanted. But respectfully, me as an expert took 10 minutes to look at that survey that's published now, and I've identified over a dozen critical issues that I shared with the staff last month, who did tell me they were excellent and that they would refer those to the board and the stakeholder council. I don't know if that has happened, but I have sat here today and I've listened to all the hard work, all the hard work and effort that you all are doing to get robust and usable data for the reviews. But I must ask, why is the patient-facing data collection so minimal and not as important moving forward as all of the other aspects of these reviews? It makes me question who these reviews are really about and who the benefactor is. It's not too late to create right surveys. And I, as an expert, our coalition, we stand by you to help you make sure that the patient surveys and the data you collect can be usable in your reviews. Thank you.
Much. Okay, any other questions or comments, rather? Okay.
We can go ahead and close this meeting out. Or,
Back into executive.
and we'll be going, right, I was gonna say, and then we'll be going back into executive session, but we're closing this meeting out.
Okay, great.
Thank
you,
you.
everyone.
Thanks to all.
And board, yeah, we'll reconvene here for another till noon.
Yeah, as soon as.
So board members, please hop
Yeah.
back on the other executive session team link.
Okay.
Till noon.
We
Yep.
hope.
Yep. We'll extend as needed. Okay, Eileen, we're